Thanks for asking me to speak about the current management of multidisciplinary management of HCC. I'll give a Canadian perspective on this. I have nothing to disclose. Um, by the end of the presentation, you will be able to recognize that there's a growing burden of hepatocellular carcinoma, uh, which patients should undergo surveillance, describe the importance of contrast imaging in the diagnosis of HCC, and list the treatment options and describe how this management is best done in a multidisciplinary team. So globally, hepatocellular carcinoma is most prevalent in Southeast Asia and Sub-Saharan Africa. But we do know that there's a big burden of this worldwide. There's more than 750,000 deaths annually due to HCC, making it the fourth leading cause of cancer-related mortality worldwide, with most causes globally being due to the hepatitis B virus, which we heard about from Dr. Alter earlier. Now, this report from the World Health Organization highlights that 3 out of the top 5 leading cancers that cause mortality, colorectal, stomach, and liver cancer, fall in the domain of gastroenterology and hepatology. And as I mentioned in my last talk, both Chile and Canada share similar problems with obesity. And it's estimated that more than 5% of cancers in our countries can be attributed to obesity. Now, there's recent data from the United States that shows that primary cancer of the liver, including HCC and intrahepatic cholangiocarcinoma, is one of only a few cancers that is on the increase in the past decade. Well, this slide summarizes the latest AASLD recommendations for surveillance. There's moderate to strong evidence that surveillance improves overall survival. It should be done with an ultrasound, and now alpha-fetoprotein has been added back to the recommendations every 6 months. Surveillance is not recommended for patients with advanced liver failure because they're often too unwell to offer therapy. So this should only be done in patients who are candidates for liver transplantation. Surveillance should be performed in patients with cirrhosis, no matter what the cause, although the risk is highest for viral hepatitis, followed by steatohepatitis from alcohol or non-alcoholic fatty liver, and then other causes of cirrhosis. And we know that non-cirrhotic carriers of hepatitis B are also at risk for hepatocellular carcinoma. And when to start screening depends on their ethnicity and their age, with Africans starting at an earlier age and starting earlier in patients with a family history, similar to what we do with colorectal cancer. Now, unfortunately, we do very poorly at surveillance, and this is a pooled analysis of more than 17,000 patients from 9 studies that found that regular surveillance was only being performed in 18% of high-risk individuals. Surveillance rates were higher if they were followed by gastroenterologists compared to primary care. But there's still a lot of room for improvement, with only half of patients followed by gastroenterologists getting regular surveillance. And when this other study looked at where the problems were with having surveillance, some patients fall off just from not being able to identify cirrhosis, as I mentioned in my last talk. But even when you know that the patient has cirrhosis, many patients are inconsistent about returning for their ultrasound every 6 months. So in Calgary, we've partnered with that same radiology group that I talked about with the NAFLD pathway to enroll patients who are high risk in an automated program where they get recall every 6 months. They have standardized reporting that comes back to us as specialists and goes to the primary care physician, and also goes to goes directly to the patient. Now, in our program, we follow the AASLD recommendations for the non-invasive diagnosis of hepatocellular carcinoma. If a small lesion is found on ultrasound, they return in 3 months. If it's increasing in size and becomes larger than 1 centimeter, then they need a contrast enhanced study. And at our center, that's usually done with MRI and with contrast enhanced ultrasound to help with the diagnosis. And for lesions that aren't characterized by either one of these studies, then sometimes a biopsy is needed. The non-invasive diagnosis of hepatocellular carcinoma takes advantage of the dual blood supply of the liver. The fact that the main blood supply from the cancer is from the artery, whereas the main blood supply to the liver is from the portal vein. So the typical pattern that you see is arterial phase enhancement. And once the contrast leaves the liver and comes through the portal vein, then the tumor looks darker than the rest of the liver, what we call washout. These two findings together in a lesion that's greater than 1 centimeter can diagnose hepatocellular carcinoma in a patient at risk with cirrhosis. Now, this can also be done with contrast enhanced ultrasound. And you see here, this nodule in the left lobe of the liver is black on grayscale ultrasound. Following the injection, it lights up very nicely. And then later in the portal venous phase, there's slow, weak washout compared to the rest of the liver. And this is diagnostic for HCC. Now, contrast enhanced ultrasound's only been recently approved in the United States, but in Canada, we have more than 15 years of experience using it. And this paper from our group shows how we would incorporate contrast enhanced ultrasound into the ASLD algorithm. So for the multidisciplinary management of HCC, there are many treatment options available. And this, therefore, is best done in a multidisciplinary team with expertise from hepatology, from liver transplantation, surgery, radiology, both diagnostic and interventional radiologists, oncologists, and other groups. Our multidisciplinary team in Calgary started in 2002 and is now organized by one of our nurse practitioners every Tuesday morning at 7 a.m. surgeon time. We meet to discuss the cases. And I'll briefly describe how we select patients in our center for different treatment options. Now, when selecting patients for treatment, it's important to consider the stage of the tumor, the performance status of the patient, and the function of the liver. And the Barcelona Clinic Liver Cancer Staging System is the preferred staging system because it takes into account all three of these factors and links patients to potentially curative or palliative treatment options. Now, it's important to remember that 90% of hepatocellular carcinoma develop in the setting of cirrhosis. And we should not do something to the liver cancer that's going to harm the liver function. The Child-Pugh classification, which uses 2 clinical findings, encephalopathy and ascites, and 3 lab tests, bilirubin, albumin, INR, and scores patients from 5 to 15 points. And Child-Pugh A is 5 or 6 points, well-compensated patients, Child-Pugh B 7 to 9, and Child-Pugh C above 10. Remember, these patients have a very high mortality from the cirrhosis itself, irregardless of the liver cancer. So several years ago, we adapted the Barcelona Clinic Liver Cancer Staging System into this Canadian HCC algorithm. And to take into account the tumor, the liver function, and some clinical questions to link patients to therapies in our Canadian context. Now, surgical resection for patients is usually reserved for a single tumor or sometimes multifocal tumors in the same lobe of the liver. It should be reserved for patients who have Child-Pugh class A cirrhosis. And even in those patients, we can stratify risk. And we know that portal hypertension and bilirubin predict survival. As you can see in this study from Barcelona, patients do worse if the bilirubin is above normal or if they have evidence of portal hypertension. In this case, this was done by hepatic venous pressure gradient measurements greater than 10. Although in our center, we just use a surrogate platelet count of 100 as a marker of portal hypertension. Now, there are randomized controlled trials that suggest that resection is superior to RFA as far as lower risk of recurrence. similar survival rates. And the problem still is that 70% of people following a resection will have a recurrence within 5 years. And in the hands of a good surgeon, postoperative mortality should be less than 2%. Now, ablation can be done using heat with radio frequency or microwave ablation or injection of 100% ethanol. And this works best for tumors that are less than 3 centimeters and usually will only treat up to 3 lesions at one session. A meta-analysis of randomized trials has shown that radiofrequency ablation is better than percutaneous ethanol injection for local control, especially when the tumors are greater than 2 centimeters. Recurrent rates are probably slightly higher than compared to surgery, and especially if they're larger than 2 centimeters. And complication following this includes bleeding, thermal injury, and remember that 1% of the time the tumor can track on the needle. So liver transplantation, according to the Milan criteria, is used in most centers, but we have, which is a single tumor less than 5 centimeters or 3 tumors less than 3 centimeters. But for several years, we've been transplanting under extended criteria in our center, and now this has been adopted across Canada. And I'll talk about total tumor volume and AFP criteria on the next slide. This is, remember, the only thing that can be offered for patients who are Child-Pugh Class C. And in carefully selected patients, recurrence rates for the Milan criteria should be less than 10% after liver transplantation, but it is higher with the extended criteria. Problems with transplantation include the organ availability, waitlist dropout, where the tumors grow beyond these criteria as patients are waiting for an organ. And of course, they have to take lifelong immunosuppression following the procedure. So our liver transplant in Edmonton several years ago analyzed the UNOS database from the United States and compared total tumor volume to different criteria, including Milan and UCSF. And we found that a total tumor volume greater than 115 cubic centimeters was a poor predictor of survival and allowed us to expand the criteria beyond the University of California, San Francisco criteria. However, it was also important that alpha-fetoprotein predicted recurrence and survival. And the cutoff that was found in our study was 400. And so we used these two in combination as our criteria for transplant. Now, I'm going to refer to this website a little bit later, which was just launched this week here in Alberta. And it has on it a total tumor volume calculator. And you can see a single tumor of 6 centimeters is within criteria. But you can actually have 7 lesions, all 3 centimeters, and also be within criteria. So TTV allows us to transplant smaller, more numerous tumors. Transarterial chemoembolization is used for intermediate stage patients. It's also done on large tumors, multifocal. These patients should be Child-Pugh A or B7, and the portal vein should be patent with flow going towards the liver to avoid liver failure as we deliver chemotherapy and particles through the arterial blood supply to the tumor. Meta-analysis of trials have shown a survival advantage in these intermediate stage patients. There are different ways to do TACE, but the drug-eluting beads are more standardized. They're more expensive, but they're also better tolerated. And the main complication is post-embolization syndrome, where patients will develop fever, nausea, or right upper quadrant pain after the procedure. We also can do transarterial radioembolization, which delivers yttrium-90 to the liver on small particles. And it's predominantly used similar to TACE in intermediate stage patients. And there are trials ongoing comparing it to chemotherapy in more advanced stage patients. The selection criteria are similar to TACE, but because it's less embolic, it's safer in patients with portal vein thrombosis. And there are now small randomized controlled trials suggesting that it may have an advantage on progression-free survival compared to conventional TACE. and radiation damage to the liver with progression of the Child-Pugh score can occur. Stereotactic body radiotherapy is another option that we have in our center, which delivers high beam radiation in 5 fractions to treat the tumor. In small case series, this is known to result in local control rates, which are actually very similar to radiofrequency ablation. It can worsen the Child-Pugh score, so we do carefully select patients. And its main side effect is this radiation damage to the liver or adjacent organs. We can also use radiation to treat bony metastases. Now, for advanced stage patients, chemotherapy is offered. This could be advanced stage due to the multifocal nature, involvement of the portal vein, lymph nodes, or metastases to distant organs like the lungs. And the first drug that was shown to have a survival benefit was sorafenib, which increased median survival from 8 months to 11 months. But we know this drug has multiple problems with nausea, diarrhea, hypertension, hand and foot syndrome. And so for 10 years, there were no real drugs that were shown to be superior to sorafenib until the arrival of lenvatinib, which in a non-inferiority trial suggested that it had similar survival and higher progression-free rates. But the real game changer came this year with the publication of this study in the New England Journal of Medicine that showed the combination of atezolizumab and bevacizumab given intravenously every 3 months showed a much better survival compared to sorafenib. And this is now our preferred first-line therapy for hepatocellular carcinoma, although unfortunately this medication costs about $250,000 annually. If patients are failing this first-line therapy with sorafenib, regorafenib, cabozantinib, and maybe nivolumab, although the primary trial did not reach its primary endpoint, may be offered in the second line. So my colleague from Edmonton, Dr. Punita Tandon, has created the Cirrhosis Care website, which we launched just earlier this week. I was one of the contributors to the hepatocellular carcinoma content. And if you visit the website, there's information for both healthcare practitioners and patients. And you can see in more detail how we use the Alberta HCC algorithm. On there, you'll also find the top tips for the management of HCC, which I've discussed in today's talk. So in conclusion, HCC is a leading cause of cancer-related mortality. Increasing incidence is happening around the world. Patients with cirrhosis and some Hep B carriers should be undergo surveillance with ultrasound and alpha-fetoprotein every 6 months. We believe that contrast-enhanced ultrasound is a very effective tool for diagnosing it, and management is best done in a multidisciplinary team. Thank you for your attention.